Hi, students. Welcome back. I hope you had a great lunch. We're so happy to have you here for the Paths 2 Project Middle School Health Science Exploration Camp. Did you enjoy the recordings and the live sessions this morning? I hope so. Next, we're going to have Ileana Elizondo with Interpreter Services. If you have any questions, make sure that you either contact us on pathcentral.org or send us an email. Talk to your teacher and they'll tell you how. Thank you.
Good morning, students. My name is Ileana Elizondo. I am the Director for Interpreting Services at DHR Health. I am myself a trilingual interpreter, English, Spanish, and American Sign Language. Buenos días a todos. Mi nombre es Ileana Elizondo. Soy la directora de servicios de interpretación aquí en DHR Health. The big question we get is, why do we have to speak Spanish? Well, most of us in this region, we are bilingual. We come from, we're very close to the border to Mexico. We have a lot of people from Mexico come in and, they speak Spanish. And as well, most of our family members, grandparents, great-grandparents know the language. I've also heard where the Spanish is kind of fading, where younger generations just kind of stop speaking the Spanish and they have issues communicating with the grandparents. And let's keep that going. Let's keep our roots going, our language. I always give an example as, let's say you're in Japan, you are in Russia, one of your bucket list trips that you want to make, and for whatever reason you get sick or you have an accident and you end up in the hospital. Everybody's talking this language that you have no clue what they're saying. Everybody wants to poke you. They want to remove your clothes. And how are you going to communicate? They don't know if you have allergies. They don't know anything. And you can't communicate because you don't understand their language and you don't speak their language. How would you feel if someone passes by and speaks your language, speaks English, and they're like, well, they're in Russia, they should learn. How would you feel? Not nice, right? So that's what happens to our community that speaks Spanish. We've heard it, we've seen it. We're like, well, you're in America, you need to learn English. No, guys, let's be nice. It doesn't cost you anything to be helpful. And trust me, that person will remember you for the rest of their life. So, like I said, most of us know Spanish, some of them don't. As a career, as a professional, as an interpreter, you have millions of doors opened. You don't count as one person, but you count as two. Me, myself, I count as three because I can communicate in English, I can communicate in Spanish, and I can most definitely communicate in American Sign Language, which is with my hands. My mom makes fun of me because she's like, oh my gosh, she loves to talk. She even talks with her hands. It sounds funny, but it's cool at the same time. So let's keep going. In English, we have you. We direct to anyone as you, not in Spanish. In Spanish, it's a big difference. You call you, it's tú, or it could be usted. Tú, it's very informal. It's like you're talking to your friends, you're talking to your cousins. Once you talk to someone that it's older than you or someone that you don't know, and even though it might be younger than you, you still refer to them as usted. Usted, it's a form of respect. So as if you can see this slide, the use of the formal usted is a sign of respect in the Spanish culture. You should always make it a priority to address everyone, whether they're older or younger than you, respectfully. In the questions and statements you will find in the booklet, we have used the formal usted instead of the familiar tú. So let's go through some vocabulary. Hello, which is hola. Good morning, buenos días. Good afternoon, buenas tardes. Good night, buenas noches. How are you? ¿Cómo está usted? May I help you? ¿Le puedo ayudar? Goodbye, adiós. Very common courtesy, cortesía común. Please, por favor. Thank you, gracias. You're welcome, de nada, o muchas de las veces se puede usar por nada. It means the same thing, it's just depending on the region where you are in Mexico that you will hear de nada o por nada. The time, la hora. Día, day. Noon, mediodía. Afternoon, tarde o después de mediodía. Evening, atardecer o tarde. Night, noche. Midnight, medianoche. Today, ahora, hoy. Tomorrow, mañana. Yesterday, ayer. What time is it? En español sería, ¿qué hora es? At what time is your appointment? ¿A qué hora es su cita? Your appointment is tomorrow. Su cita es mañana. Common questions. How are you? ¿Cómo está? ¿O cómo está usted? What is your name? ¿Cuál es su nombre? ¿Cómo se llama? What is your birthday? ¿Cuál es su fecha de nacimiento? What is your age? ¿Cuál es su edad? What is your phone number? ¿Cuál es su número de teléfono? Where do you work? ¿Dónde trabaja? Common questions. In case of an emergency, whom do we contact? En caso de emergencia, ¿a quién debemos contactar? Have you any questions? Or do you have any questions? ¿Tiene usted alguna pregunta? Do you need an interpreter? ¿Necesita un intérprete? Do you need a wheelchair? ¿Necesita una silla de ruedas? Can you move? ¿Puede moverse? Common statements. Declaraciones comunes. My name is. Mi nombre es. I am. Yo soy. Please sit. Siéntese, por favor. Please have a seat. Por favor, tome asiento. Please register. Por favor, regístrese. This way, please. Por aquí, por favor. The medical names. Nombres médicos. Nurse. La enfermera o el enfermero. Doctor. El médico o la médica. El doctor o la doctora. Doctors. Los médicos o los doctores. Physician assistant. Médico de asistente o asistente médico. Certified Nurse Assistant, CNA, asistente ayudante de enfermería. Medical Assistant, ayudante médico. Now this is the basic parts of the body. As if you noticed in our previous slides, you can see the difference in the Spanish that it's very formal. And it's always a he or a she. It's not general. So Spanish comes out to be very, very detailed and very, very expressive compared to the English language. So, okay, head, cabeza, hip, cadera, knees, rodillas, legs, piernas, mouth, boca, neck, cuello, nose, nariz, shoulder, hombros, thighs, muslo, wrist, muñeca, hand, mano. Huesos principales del cuerpo, el cráneo, cranium, clavicle, clavícula, escápula, escápula o omoplato, sternum, esternón, ribs, costillas, humerus, húmero, radius, radio, vertebrae, vértebras, ulna, cúbito, pelvis, la pelvis. It's the same, okay? So the Spanish and English, especially in the medical terminology, is very, very similar. I hope you enjoyed the Spanish. So now we're gonna jump to the American Sign Language. I hope some of you have had an encounter with a deaf person, deaf schoolmate, I don't know, something. It's fun. I know a lot of people get nervous because like, okay, how am I going to communicate? It's very easy. Either you can, on your phones, we all have a phone by now, you can message them and show them your message or write back and forth. So let's go to the American Sign Language. Effective communication is made more difficult when attempting to communicate with a person who is hearing impaired. Hearing impaired can't hear you when you speak. Now, I get this a lot. So it's like, oh, so you know how to read with your fingers. And I'm like, no, I talk with my hands. Reading with your fingers, it'll be Braille. That's for someone that is blind. Okay? When you come across a deaf person, your body language says a lot. Your facial expressions as well. And trust me, a deaf person can pick up on any little clue on your body, on your face. If you're in a bad mood, if you're answering upset, they will get that. That's just something they all know. Me as an interpreter, as a sign language interpreter, I pick up on those clues real quick. I have a lot of facial expressions. I move my hands a lot when I talk, even English or Spanish, but it's just something in me that I am already moving my hands a lot. So if you come across them, most of them know how to read your lips. So make sure you can talk just very clearly so they can read your lips and understand more or less what you're saying. Don't mumble. Don't give them your back, because if you're saying something they won't know, not one, they can't hear you, two, they can't see your lips. They won't be able to understand what you're trying to communicate to them. Okay, so now let's go with the alphabet. I'm hoping most of you have at one point in your school have come across it. So let's start with alphabet. So it's A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P. P, it's the K, but looking downwards. Okay, P, Q, it's the same as G, but downwards. Q, R, S. Now remember S and A, they get them confused a lot. So S, your thumb goes in the front. S, T, U, V, W, X, Y, and Z. So I love to sign pizza because it's a Z but with two fingers, and you do pizza with a Z, okay? And we all love pizza. So now, remember when I told you the facial expressions, your body expressions say a lot. So angry, how do we sign angry? Angry. So I can be, I'm so angry, because it doesn't match. So I have to match what I'm signing. I'm angry. Happy. So imagine if I'm so happy. it doesn't match. So you have to make it match everything you sign. Happy, yeah, I'm happy. Sad, sad. I'm scared. I'm safe. So it's two S. You start with your hands open on the back, and then you're gonna close them and make two S. Safe. Now, if you are into sports, one of the sports that has a lot of sign language, it's baseball. When baseball started, they had a player that he was deaf. So between him and the coach had to come up with a lot of signs, and those signs are still in the baseball games. Safe, and you see them, you'll be like safe, so which means you're safe. Sorry, it's with a closed hand, and you go in circles. Sorry. Hi. Good morning. Morning, why morning? Because it's the sun. The sun, it's coming up. Morning. Afternoon, because the sun is going down. This is noon. Why? Because the sun is right up on top of us during noon. So it's afternoon and then night. Why night? The sun is already going down, or it's down. What is your name? Okay, so there's different ways of signing. American Sign Language is ASL. Now we also have English Sign Language, which means I would sign word by word. So this would be, what is your name? That's an English sign. Sign language would be like, what's your name? That's it, just what name? And they'll finger spell it, Iliana. Me, as being in part of the deaf community, they assign you a sign name. My sign name is Iliana. I love motorcycles. So once we're in the deaf community and they're looking for me, they'll just be like, where? Where is she? And everybody has a sign name. Now, you can't make your own name. It has to be a deaf person to assign you your name. And usually it's going to be something that it identifies you, that makes you very unique. For me, it's the motorcycles. I love motorcycles. Recently, they've been wanting to change it to I because of my hair strike, but it's like, no. I like my motorcycles. It's very unique. So let's keep going. Come and sit, please. So it'll be come, sit, please. Or we can do it the other way. Please come and sit. Glad to meet you. So it will be nice to meet you. This is me, this is you. So we're meeting, okay? So it's nice to meet you. If the person is on any other side, you refer to them, okay? It is nice to see you. Nice to see you. So I'm signing very, very American Sign Language. I'm not doing the English. So it makes a big difference. Sign language we don't use the little words. We use just the main things. So nice to see you. Now don't do this because this means blind. So nice to blind. Yeah, no. So it's nice to see you. Sorry, I'm late. I know as students, we're always running late, right guys? From class to class. So it would be, sorry, ooh, I'm late. Look at the face, late. Or it can also mean not yet. My face moves. My face makes a difference. Late, not yet. Okay, so do you have your homework? Not yet, okay? How are you? So it's the two hands and you're gonna twist one. How are you? So it's how you, really. It's like, how are you? Fine. So fine, it's out and in. If you go upwards, that's fancy. Where are you from? Where from? I forgot your name. So it's like, ooh, name, forgot. Please repeat, which means again, repeat it, you know, so please repeat. Thank you. Okay, so thank you, it's from your chin out. Thank you. You're welcome. Welcome. From your chin inwards to your chest. Welcome. Okay, doctor. Let's do a little bit of medical terminology. Doctor, it's the D. Why here? Why in our wrist? Because this is where they take our pulse. Okay, so it's doctor with a D. N for nurse in the same area. Surgeon, so this is surgery. And then this is person, so it'll be surgery person, which means a surgeon. Specialist, so this is a specialist. They're taking a certain specific specialty, specialist, so special persons, specialist. Chiropractor, chiropractor. Why? He's kind of like popping your bones, so chiropractor. Do you need a nurse? Need nurse? You can do the question mark or just your face like need. The doctor is here. Ooh, doctor is here. So we go in little circles, motions. Doctor here. A surgeon is a specialist. So the surgeon, it's a specialist. You need to see a chiropractor. Do you need to see a chiropractor? I'm sorry. Football. Let's go into sports. Football. Football. Why football? Well, you know how a football has the white strings here? That's what you're doing. Football. Baseball. You're grabbing a bat, you're hitting. Swimming. Swimming. So as a lot of the sports, a lot of the things, it's body language. It's gestures. Walking. Could be walking or could be walking. Either or. Jogging. You're jogging or you're running. Tennis. Tennis. You're playing tennis. Wrestling. Same as kind of like the football, but you're moving your hands up and down. Wrestling. Boxing, you make the signs as you're boxing. He can box and wrestle. He can box and wrestle. Soccer. Soccer. Why? Because of the goalie. Soccer. Basketball. You're throwing a basketball. So if you play soccer, you can't play basketball. As you noticed, I did it very, very English. Golf. So the same, you're gonna swing. Golf. Mark, you would fingerspell. Mark, it's good. Golfer. Frequently used signs. So boy, this is boy. In sign language, in American Sign Language, because it's not universal, guys. Each language has their own signs. So this is American Sign Language. For America, anything up here, it's gonna be a male. Anything down here, it's a female, okay? So boy. little boy. It would be man, grandfather, father, cousin, uncle, brother. Now let's move to the females. Girl. This is girl. Mother, grandmother, sister, aunt, cousin, which means cousin female, cousin male, okay? Who? What? So it could be what or it could be what, depending. You can use both. This is more as an expression like what? Like what are you telling me? Or like what's your name? Where? When? Why? Why are you falling asleep? Why? How? You have both hands and you do one. How? How? Which? This one or this one? Which? More. Interpreter. Hello. Okay, so, and then it's goodbye or goodbye. We all use the I love you hand. Do you all know why the I love you? Okay, I'll explain it. It's the I for I, the L for love, and the Y for you. I love you. Okay, guys, so this completes my presentation. So now I'm going to show you how I would sign a song. I hope you enjoy it. I hope you like it. And keep up. And I know we're going through something a little different, but I hope you enjoy it. Have fun, stay safe, and enjoy the song.
There's a fire starting in my heart, reaching a fever pitch that's bringing me out the dark. Finally, I can see you crystal clear. Go ahead and sell me out and I'll lay your ship bare. See, I'll leave with every piece of you. Don't underestimate the things that I will do. There's a fire starting in my heart, reaching a fever pitch and it's bringing me out the dark. The scars of your love remind me of us. They keep me thinking, look, we almost had it all. The scars of
Thank you, guys.
Hello, PATH students. My name is Diana Castillo Gauna, and I am the American Heart Association Training Center Coordinator here at DHR Health. Today, I'm here to speak to you about how to perform basic life support, or something you might know as CPR. So this is something very good to know whether you're in the school setting or even now that you're at home. It is something very good for you to know because you never know when this might happen, okay? So I'm gonna go through each step, the basic steps for you to perform BLS, okay? So one of the very first things that you wanna make sure that you do is that you make sure that the scene is safe, right? We wanna make sure there's no spilled water, no electrical cords, nothing in your way that might cause harm to yourself, okay? So we'll approach our individual. We always want to make sure that they are responsive, right? So we'll start off with, sir, hey, are you okay? There's no response. So next what we do is we check for pulse, and we also check for respirations. And we're doing that between 5 to 10 seconds, okay? So let's check for pulse and breathing. And this is something that you can do simultaneously. We are checking the carotid pulse as well as looking over and making sure there is no chest rise, okay? So once we are between those 5 to 10 seconds, we realize that there's no pulse, there's no breathing, so we want to call for help, you know. If there's somebody else with you in the room, somebody else with you at home, you tell them, hey, you, call 911, bring me an AED if you do have one at your facility, okay? So after we have called for help, we will automatically come to doing compressions. Now the compression rate for the adult is we want to do 30 compressions, and then we will provide 2 breaths, okay? When we are doing our compressions, we want to make sure that we are going in 2 inches deep, as well as in between 100 to 120 beats per minute, okay? So I'm going to demonstrate to you how we're doing compressions. So while I'm doing my compressions, you will see the blood flowing, and you will see his forehead turn red, and this means that everything is being done correctly, okay? So I'm gonna go ahead and start my compressions. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. Okay, so here we are using a bag to give our breaths. So we are giving 2 breaths. We always want to make sure that we are tilting the head back to allow the breaths to go through. As soon as we're done with our breaths, we'll continue with compressions until help has arrived. 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 25, 26, 27, 28, 29, 30.
I know BLS. I will take over compressions. Here's
Super.
the AED.
Thank you.
1, 2, 3, 4, 5.
So these are your
6,
AED
7,
pads.
11.
One will go up on this right side, right up on the top, and the other one will go
22.
right here on the side.
27, 28, 29, 30.
We will turn on the AED,
1, 2, 3, 4,
Apply pads
5,
to
6,
plug in the connector.
8, 9, 10.
Do not touch.
Do not touch the patient, stand
Everybody clear?
clear.
Shock advised.
We will resume compressions until it's ready to charge. 4, 5, 6,
Stay clear
7,
of patient.
8.
Stand clear.
Everybody's clear?
Deliver shock now.
Everybody's
Press
clear?
the orange button now. Shock delivered.
I will resume compressions.
And then we automatically resume compressions until help is here.
5, 6.
So now we will cover the basic steps on how to perform CPR on a baby or on an infant. There are a couple of differences between performing these steps versus on an adult. One of the biggest differences here is that we are checking for the pulse at the brachial. So this is going to be the part in between the elbow and the armpit. So right here in between the arm is where we'll be checking for pulse. Right, so this is something we do check between 5 to 10 seconds. And another difference is how we check if they're responsive. On the adult, we kind of do pat them on the chest, right? Hey, are you okay? But on a baby, we are actually tapping their feet, right? This is where they're most sensitive as infants. So we kind of want to tap them, kind of tickle them, just to kind of stimulate them to see if they are responsive. Okay, so from the very beginning, we do make sure that the scene is safe. We make sure again that there's nothing around that's going to cause harm to ourselves, right? So we'll tap them, baby, baby, are you okay? There's no response, so we'll be checking for pulse and we'll be checking for breathing for that chest elevation between 5 to 10 seconds. We see that there's no pulse, no breathing. We'll automatically shout for help. Hey, you, bring me the AED, call 911, and we'll automatically start with compressions. Now, on a baby, compressions are done going in at a depth of 1.5 inches. So we can do this one or two ways. You can do it using your 2 fingers. So we'll do compressions this way. Or we can also do it using our 2 thumbs, whatever's more comfortable for you. And this is what the thumbs would look like. Okay, I myself will be doing it with my thumbs as I do find that much easier. So on a baby, if you are by yourself, you are doing a compressions at the rate of 30 compressions and 2 breaths. Okay, so we'll go ahead and start that. Ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 26, 27, 28, 29, 30. So we will give our 2 breaths. Okay, another round of compressions. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. We'll give another 2 breaths using our barrier device. Once help has arrived, they will bring you what is an AED. As mentioned before, every AED is different. It comes with different instructions, but do not panic. All we have to do is simply turn on the AED, and it'll prompt you with directions.
Apply pads to patient's bare chest. Plug in pads connector next to flashing
So on
light.
an infant, we are putting the pads right in the center in the middle.
Apply pads. Plug
We
in
will turn the
connector.
baby over and we'll put one right in the back in the middle.
Analyzing heart rhythm. Do not touch the patient.
Stay clear. We want to make sure that nobody is touching the patient while the AED is analyzing.
Shock advised. Charging. Stay clear of patient.
Stay clear.
Deliver shock now. Press the orange button now.
Everybody is clear. We'll go ahead and press the shock button.
Shock delivered. Begin CPR.
And we will resume with compressions. So we will do this until help has arrived. Once EMS or paramedics do arrive, they will take over. And thank you for joining me on how to perform BLS on both an adult and an infant. And just a few reminders, we know that sometimes out in the real world, we don't carry those barrier devices. You know, when you are giving breaths to another individual, we don't want those diseases or germs spreading. So we do ask that if you don't know the individual, if they're not your family members, we just really recommend that we don't give the breaths. What we recommend is that you do 5 cycles of the compressions. And after your 5 cycles, you will check for a pulse. If there's still no pulse, you will continue with compressions until help arrives. Another thing that I know that does make us very nervous is how to use an AED. What I can recommend is always to turn on your AED first, and the AED will give you exact directions and the steps to follow. And that is all here for the adult BLS CPR.
Good afternoon, students. My name is Megan Molina, and I'm going to be talking to you today about trauma services and injury prevention. Before we get started, just a reminder, this is a live segment where you'll have the opportunity to ask questions. I will answer questions after I share a little bit about myself and what I do here. And so if you'd like to submit questions, you can do that by scanning the QR code on screen, or you can go to www.menti, which is MENTI.com, and the access code is 53820568. So again, you can either scan the QR code on your screen, or you can go to www.menti.com and use the access code 53820568. And then we'll get to your questions in just a little bit. So like I said, my name is Megan. I'm with Trauma Services. More specifically, I'm with Injury Prevention. I was born in Georgia and grew up actually in Venezuela and Mexico, but the Valley is home. I've been here since I was a senior in high school. Moved here when I was about to turn 17, turning 18. I went to school here in the Valley, and so this is home for me. I've been a nurse for over 6 years now. 3 of those were in the ER, and 3 of those were doing trauma ER specifically. And I've now been in this role doing injury prevention for about a month. So something fairly new for me, but trauma I've been doing for a while now. I always knew I wanted to be a nurse since I was younger. Growing up overseas, my family and I, we worked with a lot of communities that needed help in different ways, education and just different areas. And I loved helping people. I loved working with people, very outgoing person. And so I just knew that nursing was a natural choice for me because I really liked helping people. And that's why I chose nursing. When I first wanted to become a nurse, I thought I wanted to take care of labor and delivery. So those are the mothers who are going to give birth. And I thought, this is for me. That's what I wanted to do. But the beautiful thing about nursing is there's so many areas. And when I was in school, I did a rotation, which are basically classes at the hospital, clinicals. And I did my rotation in labor and delivery and found out it was not for me. And so the nice thing is I then had the chance to go to the ER, loved it, and I thought, this is the area that I want to work in. And so if nursing is something you're considering, it's something to keep in mind is you might think you want to work in one area, but once you're in school and you get to experience different areas of the hospital or maybe even outside the hospital, you'll then find an area that you like if nursing is for you. And so to become a nurse, it took me about a year of taking my prerequisites. Those are classes that you have to take before you can even apply to any nursing program. And those are general classes, sciences, anatomy, physiology, English, algebra. And then based on your grades in those classes, you then apply for a nursing program. I chose to go to STC because it was a 2-year program. And I liked that after 2 years, I would be able to start working as a nurse, as opposed to Pan Am, which is a little bit longer. And so that's why I chose that school. And so after I actually got accepted into the program, it's 2 years long, and those 2 years, they're hard. I would say that's the hardest part of all of my education were those 2 years getting my associate's degree, becoming a registered nurse. You have classes that are in the actual school themselves, talking about theory, learning the concepts, and then you're in the hospital. Like I said, you're in the clinicals, and that's where you kind of get to apply what you learned in the classroom setting. You're then applying it in the hospital, and you're learning along outside other nurses, and so it's really cool to see how the classroom then translate into hands-on. After that, I started working. I actually worked here at DHR as an ER nurse for 3 years. During that time, I decided to get my bachelor's. That took me about 2 years just because I took only about 1 or 2 classes at a time. I was paying for school by myself, and I was working full-time, and so I just took 1 class at a time. I did what was doable for me. It took me a little bit longer than some people, but that's how I was able to do it. I was able to pay for it. It was just 1 class at a time and kind of go from there. So after I'd been here about 3 years, I got the opportunity to apply for a program in San Antonio, and it was called the Trauma Nurse Fellowship. And that fellowship was about 6 months long, and I got to take care of the trauma patient in their whole rotation. So I got to go out with EMTs and pick up patients in the field. I got to fly with AirLife in the helicopter, picking up patients from scene, from car accidents or different things like that. I got to take care of patients in the actual ER that were trauma. I did administration, OR. It was a great opportunity. I learned so much. I grew, and I ended up staying at that hospital in San Antonio, which was a level 1 trauma center, which is the highest level, for 3 years. And now I've just come back home. Now I'm doing injury prevention, and injury prevention is trying to prevent the trauma before it happens. And so what I do is I go out into the community and address those highest mechanisms. So for the Valley, our number 1 trauma is falls. Which of course is mainly by our older adults. And so we have a program called Bingo Size, where I go to the community with older adults and we play bingo, but we also exercise. And so it helps them increase their strength and their balance. And so these things are hopefully to prevent them having a fall, and it's preventing trauma. We also do, for example, ATV safety. An ATV is a all-terrain vehicle, so like a four-wheeler, a dirt bike, probably some things that you guys use on your time at home or maybe at the ranch. Since COVID, we've seen an increase in these accidents, probably because people are home and they're not working or at school, and so we've had a lot more accidents like that coming into the ER. And so if you are driving those vehicles, be careful. You need to wear a helmet. Do not drive them on pavement. They're meant to be off terrain, so on dirt roads, things like that, but not on the main road. Making sure that you're wearing long sleeves, long pants. If you were to fall off of a dirt bike or a four-wheeler, you're going to come into the ER, and we see it all the time with lots of scrapes and cuts. And what we have to do is clean those out so you don't get an infection. It's very painful, so you want to avoid that happening to you. Make sure that if you are riding a four-wheeler, if it's only for 2 people, only have 2 people on that vehicle. If you have more people, it's dangerous. Another program we have is Stop the Bleed. So if someone were to get hurt, we go to the community and we teach them what to do, how to stop that bleed. And I'm not going to go into depth of the class, it's an hour long, but just a couple things for you guys to know now are the ABCs of bleeding. So A, which is to alert, call 911, get help. If you're home, let your parents know. And tell someone, hey, call 911 right now. That's your very first step. B is bleeding, and you want to identify where the bleeding is coming from. And C is compress. Just put pressure. Whatever you have. You can put gauze, you can put a t-shirt, you can put a towel. Whatever you have, you're going to put that over the wound, and you're going to hold pressure with both hands. You're not going to stop holding pressure until the ambulance gets there. Okay, so that's just a little bit of prevention for you guys to know that you might need in your everyday life. What does a day look like for me? Every day is a little different. Mostly I'm out in the community. I come into work. I work in an office setting right now with injury prevention, and I see what I'm going to do for the day. Am I going to go give a class for bingo size? Am I going to go teach a Stop the Bleed? A couple weeks ago, we went to the airport, and we taught their staff about what to do if someone were to get injured, how to put a tourniquet on, how to put pressure. And so every day is a little bit different. Our team is big. We have nurses. We work with doctors. We work with the ER staff. We work with the community, with law enforcement. So it's a lot of people on the team. Some things to think about if you're thinking about nursing. Sometimes people ask some tips that, what you can do to start working towards that. Just now in your classes, the big things I would say is become strong readers and strong writers. A nursing school is a lot of reading and a lot of taking notes. And so even now in middle school, you can start developing those skills. Really be intentional about reading and finding what's important, taking notes, becoming a strong writer. All those things are going to translate later on when you take your college courses, as well as sciences. It is a lot of sciences for your prereqs, those classes that you have to take before you even apply for the program. You have to take anatomy and physiology and 1 and 2. You have to take microbiology. And so if you can really just focus on your science classes right now, some of that's going to translate later on as well. So don't think that what you're doing right now doesn't matter. It does. It's going to help you be prepared when you get to college. And if you were to make the decision for nursing, those are kind of some things that you can focus on. Okay, let's see if we have any questions. Nope, not yet. Oh, yes. When did you know you wanted to go into the medical field? Like I said, I knew since I was very young. There was a small time that I wanted to be a vet, but that was still in the medical vein. Then I went back to people. I always wanted to be a nurse. I was very interested just by the medical field and everything it had to do with it, especially ER. It's different every day. You go in, you don't know what you're going to get. Maybe you're going to take care of a few patients, but you might have a lot of patients that come in, all for different things. It's a very strong team environment. You have to work together in order to take care of those patients, and so I love that environment. How do you deal with bad news for patients? It's hard. I think especially in the ER, sometimes that is definitely a reality, and you just have to remember that this is their worst day and you have to be there for them. Sometimes you kind of have to take your emotions out of it a little bit. You want to feel, you want to know the pain they're feeling, but you have to also be there for them. You need to be strong for them. It's hard. It doesn't ever get easy, and you don't want it to get easy because that means that you're human and that you have compassion and you care for those people. What is my schedule like? So right now with injury prevention, I have it's an office job. So it's Monday through Friday, going at 8 o'clock in the morning and get out about 5. Sometimes we have events on the weekends, like this weekend. We're going to be helping with doing car seat checks, making sure that car seats are installed properly so that if someone were to be in a car accident and there's a child in the car, want to make sure they're well protected. That's also part of injury prevention. When I worked in the ER, it was a 12-hour day. So I would go in at 6:45 a.m. And I would work 12 hours and leave about 7 o'clock, 7:30 at night. And that was usually working about 3 days a week. Also something to think about that I didn't think about when I was younger and when I was becoming a nurse is people get hurt all the time, even on holidays, even on weekends. And so you have to also think about that as part of your schedule is you will have to work, if you choose to work maybe in a hospital setting like I did in the ER, you will work weekends, you will have to work holidays. What's the part of my job that I like the best? With what I'm doing right now in injury prevention, I like being in the community. I love meeting people, talking to them, sharing my knowledge with them. I think that my time as a trauma nurse for the last 3 years really helped what I'm doing now because I've seen a lot of trauma. And so it's easier to educate because I've seen it firsthand. And so I love talking to people, sharing knowledge I have, and then also hearing from them about their life experiences and things that they're going through. How do you deal with stress and loss? I think you depend on each other as a team, especially in the ER. Nobody else has gone through it except for those who are right there with you. You can come home and you can tell your family about it, but they don't know how it feels because they weren't there with you. And so you become very close with your team, and that's your support system. They know what it feels like to lose someone. They know what it feels like to be stressed. And so that's kind of like our therapy is just spending time with each other even outside of work. How do you know if it's for you? I think I knew since I was younger, but I think some advice I could give to you would be if you have any family members or maybe family friends that are in the medical profession, whether it be nursing or nursing tech or a doctor or a respiratory therapist, all these things, ask them about their job. Ask them what they do. Ask them if they like it, what parts they like, what parts they don't like. So you can kind of get a better sense of what the job is. I did have classmates that went to school with me that after a period of time, they became nurses and it wasn't for them and they didn't like it. And so I think to kind of avoid that, just talk to people who are actually doing it and kind of hear their perspective. Oops, I'm just going to turn my phone off here. What college did I go to? So like I mentioned, I was at STC first. That's where I got my associate's degree. That was 2 years. And then afterwards, I did my bachelor's. It was at UT Arlington. It was completely online, so that was very convenient for me because I was able to work full-time and just take one class at a time. Someone's asking what my GPA was. My GPA, I don't remember what it was exactly when I applied for nursing school, but I do know that I had almost A's in all the classes because in order to get into nursing school, it is very competitive. And so those classes that you take before you apply, that's what they look at for who gets in. And so you do need to really try and do your best and do well on those classes because that's what they look at least for STC. I'm not sure what UTRGV's process is. I'm sure it's probably similar. So those classes, that's what they're looking at. So I know I had classmates who had to retake classes to get better grades in order to get into their program. What was the first time you treated a patient and what was it like? I don't remember the very first time I treated a patient. In nursing school, like I said, you're at the hospital, you're doing clinicals, and so you're in different areas. You might be like on a surgical floor or a medicine floor. I do remember my first rotation in the ER. I was supposed to be in the labor delivery floor, but there wasn't much going on, and so I got to go down to the ER and I got to start my first IV. I loved it because it was very hands-on. And I just really liked that environment. It was very fast-paced. It was, like I said, a lot of teamwork. You're not just working with nurses, but you're also working with your techs, your respiratory therapist, the doctors. You have to have good communication because there's a lot of people that are involved with the process. What's the most common things you do at your job? So in the ER, of course, it's taking care of those patients who come in who've had some kind of trauma. Also in the main ER, you're taking care of medical emergencies. So maybe someone who has had a heart attack or a stroke. People come to the ER for different things. And so when the patient first comes in and we start an assessment, we check them out from head to toe to see if they have injuries, and then kind of go from there. Do they need a CT scan? Do they need blood drawn? Do we need to give them medication? And we go from there. Can you describe a difficult emergency case and how you handled it? When I was in San Antonio, we had a very difficult situation where a family was in a car accident. Aunt was driving. She had her 2 children, and she also had her nephew with her. And none of the children were wearing seatbelts, and they were not in car seats. And her nephew was thrown from the vehicle and killed. And she was my patient, and we had to go to her. She kept asking about that child. We had to go to her and tell her what happened. Her life changed that day. Her family's life changed that day. And it was very difficult. Again, you have to just put the patient first and be as comforting as you can. There's really not much you can say in that situation that's going to make things better. And so we just try and focus on what we can, which is helping with pain, making them as comfortable as we can, and communicating with them. Especially with COVID, it's been difficult because we didn't allow family members to be with the patients. And so in situations like that, it's difficult because you've just gotten this horrible news and you're by yourself. You can't have somebody else back there with you to comfort you. And so that's been a whole nother component of nursing is trying to be that person's family member because you may be the only person that they have at that time. Let's see here. What inspired you to become a trauma-certified registered nurse? So the difference between being a registered nurse or a Bachelor of Science, a BSN, and a certified nurse is you take a national exam. So I am trauma-certified. It's an exam. I believe you have to have at least 2 years of experience in the area that you want to become certified. So you can be certified in trauma. You could be certified in emergency medicine, or emergency nursing, critical care nursing, and then it's an exam that you have to sit for, a national exam and pass. And then you have to actually continue taking education classes throughout the year to maintain that certification. What drew me to trauma specifically, when I was in the ER, I just really enjoyed taking care of those patients. I liked seeing that something was broken and that we could fix it. It was a little bit more concrete than maybe medicine. And again, the difference between trauma and medicine, trauma is a force that happens to the body. So for example, in a fall, it's the body hitting the ground or hitting furniture. ATV crash, the body hitting maybe the ground when they're thrown from it or another vehicle. Whereas medicine is something that's more internal, might be a heart issue, might be diabetes. It's something that's more internal that's happening. And so trauma just always fascinated me, and that's what drew me towards that. How do you get along with coworkers? Good. Of course, I'm not going to say that everything's always perfect. I think that the ER especially draws a lot of personalities, and everybody has different opinions and thoughts. But when you're working together for the patient, that's all that matters. The patient is the center, and we're doing everything we can to help that person. And so we work together, and so it's an awesome environment, and I get along really well with my coworkers. Have you ever made a mistake or gave a misdiagnosis, and what did you do to fix it? I think that I've never given like a wrong medication or anything like that. I have seen a provider, not at this hospital, come in and give the wrong patient a diagnosis. Like for example, 2 gentlemen with similar mechanisms, like both were in a car crash and both were in rooms next to each other, and he went in and told one patient that, for example, he had a a contusion on his lung, but it was actually the patient that was next to him. With something like that, once we realize that there's been a mistake, honesty. Just go in and explain what happened and apologize. Of course, those are not the kind of situations that we want to happen, but we are humans and errors do happen. But I think the best policy is to be honest, and in that case, nobody was hurt, so thank goodness. Some advice that I would give my younger self at the start of my career, I think is don't be scared. I graduated high school and went straight into the program. I was the youngest in my class. My time in the ER for about 2 years, I was the youngest in the unit. And so sometimes I just felt like I didn't know if I was capable of doing all the things I needed to do. Was I mature enough to handle some of these situations that were difficult with people losing family members, losing children, losing parents? But I think self-talk is powerful. I just told myself, I can do this, just keep going. And that really helped me get through a lot. It still does. I'm sure, you can kind of do that in your own schooling too. You get nervous about something and you just tell yourself, I've got this, just keep going, fake it till you make it, or just keep going until you are doing it. That's helped me so much. What do you think? What do you think is the most important trait that a person needs to succeed? I think determination. That's the biggest thing, and hardworking. I grew up with 2 siblings who were very smart. School was very easy for them. It was not for me. Nursing school, I had no life. I studied every day. I'd get up at 6 o'clock, get to the school when it opened, and studied for 2-3 hours before class started. I'd have class, I'd go to the library, and I would study until it closed. I'd come home, review my notes one more time, and go to sleep. And I did that every single day. Sunday was the only day that I would take half the day to rest and recoup. And so I don't think that I became a nurse because I was very smart. I think it's because I worked hard. And so I think that's the most important thing. It doesn't matter if you think that you're not able or you're not smart enough. You are, if you can just work hard. Just being determined. That's the biggest trait, I think, or has been true for me. Is there any types of Grey's Anatomy situation going on? Yes and no. I mean, I think some of the medical things are true from the show. Actually, when I was working in San Antonio, one of our residents who was graduating, he actually got hired to be a writer on the show. So they're hiring real doctors to write their storylines, but some of the drama and all that is definitely exaggerated. There's one scene I remember where they have 3 doctors walking one patient in the hallway. 3 doctors would never walk one patient in the hallway. It would be physical therapy, occupational therapy, nursing maybe. So some of it's definitely not true, but some of the medical storylines are true. So yeah. Let's see here if there's any other questions. Are some days hard for you? Yes, definitely. Some days are hard. Some days you do question, why am I doing this? But then you remember why you started, which was to help people, and that's your motivation and that's your focus, and it pushes you through those days that are hard. And like I said, also having a good, strong team, that also makes those hard days more doable because you've gone through it together. And so you can talk about it, you debrief afterwards, and you just come back the next day thinking that hopefully tomorrow is going to be a better day. And there are things that are exciting and good, especially if you work in certain areas of the hospital. I'm sure labor and delivery there's a lot of joy because babies are born and people get better. But in the ER, I would say that most of the people that are there, that wasn't their plan to come to the ER that day. So most of the people that we encounter, they're in hard situations, and so it makes for hard days. That's for sure. Okay, let's see if we have any more questions. How old were you when you started? So I was... As a senior, I took some dual enrollment classes, and so I got some of my prerequisite classes done before I graduated high school. And so I was 17, 18 when I started taking those classes. And I was 21 when I became an actual nurse. Turned 21 in November and became a nurse in January. So I think that's all for today. If you have any questions, you can always contact us. If you call the DHR line, the operator, you ask for trauma services. I'm in trauma services with injury prevention and outreach. My name is Megan Molina. If you have questions about anything, schooling, nursing, anything at all, I would love to talk to you all, and you can contact me at any time. And thank you.
Hello, PATH students. My name is Marina Ibarra. I'm a licensed professional counselor, also known as an LPC. I got my bachelor's degree here at UTRGV. It took 4 years to complete my bachelor's. I then decided to get my master's degree in clinical psychology. I then tested to become a licensed professional counselor. While you're attempting to become a licensed professional counselor, you need to obtain a supervisor, and that usually takes about 2 years to complete, right? Right now I'm working here at DHR as a primary child therapist. I work with children from ages 4 to 12 and usually provide group therapy, individual therapy, and treatment planning. I always knew I wanted to become a therapist because I became interested in psychology early on while I was obtaining my associate's degree. I attended school, like I mentioned before, at UTRGV. I got my bachelor's there and also my master's there. I paid for school through financial aid, so fortunately for me, I was able to obtain a loan, and that's how I was able to finish my schooling. The hardest part about finishing my schooling was the time. So a lot of people finish after their 4 years, but in order to become an LPC, you need those 2 additional years and then 2 years of training. So while all my friends were able to start with their careers, I had to wait a little bit longer, and I think that was the hardest part while I was obtaining my career. A day in my life looks like working with nurses. I work in a multidisciplinary team with pharmacists, nurses, psychiatrists, and case managers. So basically what we do is we try to figure out the best treatment plan for the patient that we're seeing. For me, that would be children. And so it's always a lot of fun. Some of my favorite things to do at work is, provide group to the children. It's always fun whenever they say, they're having fun by learning about emotions and other coping skills and things like that. The skills that are necessary to become an LPC would be, to have patience, to be empathic, to be able to listen, and also de-escalate situations that are, very intense sometimes. If you have a child who's maybe becoming a little bit irritable or maybe even sad, you have to learn how to de-escalate without feeling stressed. So some fun facts about me is that, I like to play guitar, and sometimes I introduce the hobbies that I like into groups. So for example, I also like to draw and paint. So we do a lot of art therapy type of groups where I have the children paint or, listen to music and things like that. So some helpful tips if you're interested in becoming a licensed professional counselor would be to speak to an advisor to see what path is best for you. So there are different ways of becoming a licensed professional counselor. One way would be, obtaining your bachelor's degree, and it's usually within the social sciences. So it could be anything like psychology, rehab counseling, or even education. From there, you would have to get a master's degree, which is a 2-year degree, and it could be either in clinical psychology, rehab counseling, or education and counseling as well. From there, you need to make sure that you're eligible to sit for the national counseling exam, and if you pass that, then you'll be able to apply to become an LPC. And some advice that I give you guys is that, if you have a goal or any type of dream, to make sure that you never give up. If you ever need help with anything, you can always reach out to an advisor, a teacher, or even to me. I'll provide you guys with my office phone number or also the contact information to my supervisor if you're ever interested in interning with us. So My office number is going to be 956-362-2720. You can also reach out to my supervisor, Jacqueline Mujica, and she'll go ahead and point you to the right direction if you ever want to pursue a internship with us. So again, guys, this profession is so dear to my heart, and hopefully you guys learned something in regards to how to get there. Like I mentioned before, I became really interested in counseling and psychology early on in college when I started taking that intro to psychology class. And the reason for that was because I saw a lot of my friends struggling with depression and anxiety. And so I felt that, you know, I wanted to pursue a career where I could help others whenever they're feeling this way. So right now, because of COVID-19, I see a lot of patients maybe feel a little bit anxious because of the isolation and even just, you know, fearful of, catching that virus. So something that I always tell them is, you know, exercise those coping skills. Some of those things include, you know, journaling, expressing your feelings through art, also listening to calming and soothing music. I know sometimes that can be very relaxing and we sometimes forget to do stuff like that. Also going for a walk with a friend, that exercise is really important, even if it's just for a little bit, at least 30 minutes a day or so. That could be something that, you know, people could implement every day so that they're able to de-stress. So thank you guys again, and hopefully you can reach out to me if you're ever interested or have any questions.
Hi students, my name is Abraham Aguilar. I'm an occupational therapist at DHR Health. I'd like to take the time to thank Past Project for allowing me the opportunity to speak about occupational therapy. So a quick overview of what will be discussed today. I'll define what occupational therapy is. I'll describe a typical day at Therapy Institute, which is the clinic where I work. And I'll talk a little bit about the future of occupational therapy, some exciting stuff there. So at DHR Health Therapy Institute, there are 3 occupational therapists. I joined the team last year of 2019, but I've been with DHR since 2011. During that time, I've worked at the main hospital and the rehab center. I completed my master's in 2010, and I will begin my doctorates this year in the fall in 2020. I'm certified in a couple of certifications that deal with neurological conditions. So my main areas of focus in therapy are people who've had brain injuries, strokes, spinal cord injuries, or other neurological diagnoses. But I also see patients who've had other diagnoses like amputations or recent surgeries. Fun fact about myself is over the past few years, I've gone into doing Spartan races with my son. So it's an outdoor running event with obstacle courses, and we obviously have to work out and train for it. But if we're going to promote health, we should also try to live that example. So one of the things that I like to do is bring some of those workouts into the therapy session. There's plenty of young patients that enjoy working out, but because of their illness or injury, they have a hard time. So there's ways of modifying the activity or using special equipment that allows them to do some of these CrossFit or gym workouts that you normally see. So what is occupational therapy? Occupational therapy is a healthcare profession that works towards the prevention of disability and restoration of independent functional ability. What do? They work with people of any age to promote health, prevent disability, and develop or maintain abilities. So if somebody has a condition or an illness, and they have a hard time doing day-to-day activities or doing some recreational activities, then we work with them to try to make them as independent and as functional as possible. OTs work in a variety of different settings. Some examples there are at the hospital, mental health clinics, the schools, community-based centers, nursing homes, home health, just to name a few. And depending on the setting, occupational therapy is going to look a little bit different, but we're all working under that philosophy of regaining function and making people as independent as possible. So a typical day at DHR Health Therapy Institute, normally I see about 6 to 8 patients. Again, these are patients who've had some sort of brain injury or some sort of recent surgery. And what we do with them is we do a variety of different activities. We'll do some exercises to try to regain some function. But because if they might also have weakness, they might also have a hard time doing simple things like getting in and out of the house, getting in and out of the bed or a car, or even dressing themselves. So we work on those type of things as well. Some of them enjoy doing recreational activities like, say, riding their bike or playing golf. And so we also use those activities in their therapy session to make it fun and to make it functional. There's a lot of education that goes on with the family and the patient. Sometimes they need special equipment, or they just need some education on things they can do at home. So there's a lot of training with the family and the patient. All the things that we do in the therapy are evidence-based, meaning we look at the research, we see what studies say are the most effective interventions, and that's what we do with the patients so that way we get the best results with them. Some specialty areas that OTs can focus on an outpatient clinic is they can get a specialty in, say, hand rehab, driving rehab, community mobility, vision rehab, and there's a few other ones, but those are the main ones on an outpatient basis. We also work alongside other healthcare professionals as a team, so we will work with speech pathologists, we'll work with physical therapists, and in some settings, nurses and other doctors. So what does the outlook look for as the OT profession? Well, according to the U.S. Bureau of Labor and Statistics, employment of the occupational therapist is projected to grow 18% from 2018 to 2028, which is much faster than in average of all the occupations. So that's pretty much for all healthcare-related jobs and professionals. They're always going to have a job in the workforce. How does one become an occupational therapist? It is a graduate program, so you'll have to get your bachelor's, typically something related like biology or rehab, and then you apply to a program which can be very competitive. At the moment, it's a master's program, but in the next few years, it's going to be transitioning to a doctorate program. So basically what that means is once you get your bachelor's and you apply to one of these programs, if you're accepted, upon completion, you'll get both a master's and a doctorate degree. Some things that I wish I knew when I was younger, before I started school, is how to pay for school and try to avoid student loans. I have a son that'll be a senior, so one of the things I tell him is get your resume ready. So that means getting good grades, being part of extracurricular activities, doing some sort of activities in the community. That's going to help with not only school applications, but applying to scholarships and grants. That's free money. All you have to do is search for them. There's apps that help you search for these scholarships and grants. You might just have to fill out an application and write a letter, but it's free money. So it's definitely worth the investment of time. You can also work and save, and if you start working and handling money, then you definitely need to get on a budget. And also do your research on the schools. See what the cost is on different schools. How much cheaper is it if you stay in Texas as opposed to going out of Texas? So all these things will help you if you start looking into a career in occupational therapy. So there's some exciting things happening with rehab in general. Over the last few years, there's been a boom in technology. You might have already seen some of this on TV, but there's a lot of technology that's being incorporated into rehabilitation. Everything from robotics to virtual reality systems and other different kind of mechanic and robotic and electrical equipment. And that's only going to keep on advancing and get more sophisticated. So if you enjoy trying to help people, if you enjoy learning about the human body and how it works and functions, if you enjoy learning about the brain and you enjoy technology, then definitely look into a career in not just occupational therapy, but some of the allied healthcare professions, where it's going to just be explosive with all these high-tech equipment in the future. Again, students, thank you for your attention. Stay safe.
Welcome, students. My name is Mark Gallegos, and I'm an exercise physiologist. I work here at DHR Health, Bariatric and Metabolic Institute. What got me interested in this profession was growing up, I was very much into sports, but lacking confidence. Exercise, fitness, it helped me build that confidence with that increase and improvement in confidence, I wanted to help other people feel that same feeling of confidence that they may have been lacking prior. In order to get into this profession, you need to have a bachelor's degree, at least, in kinesiology or exercise science. A typical day working at this clinic, I'm educating patients on proper ways to correctly do exercises, as well as understanding body movements, body alignment, things like that. In order to be successful at this career, one definitely needs to have education and knowledge in exercise, but also compassion, sympathy, and also an ability to communicate that knowledge into the patients so that they can understand how to properly do things as well. Here at the Bariatric and Metabolic Institute, we deal mostly with patients that suffer from obesity. Here at the clinic, we have surgeons that do the bariatric procedures. We have dietitians as well that target the nutritional habits. We have a psychologist that targets anybody that may have any mental health issues. And then myself as well. So it's a well-run program that targets every aspect of obesity and how to improve these people's lives for the better. So in respect to my current position, since I am dealing with a lot of obese patients, many of them are very limited in their mobility. So we have to basically start from the very beginning, very basic, in order for them to kind of slowly climb to improving their mobility and also their flexibility, their endurance, and their strength as well. Working in this current position, it's been very rewarding. I see individuals walk in the doors with very little confidence to the point where they can't even look at themselves in the mirror. By the time they finish through the program, they have an increased confidence in themselves, then they're ready to tackle the world. For anybody that's interested in the career in exercise physiology or anything in that nature, you can definitely go to the University of Texas in Rio Grande Valley. There's a great program there in exercise science or kinesiology. And a bit of advice that I would give to you, yes, it is about exercise and it is about teaching people how to exercise, but it's one thing to teach them how to exercise and it's another to teach them how to want to exercise. So you have to be able to motivate them and inspire them and make them feel like they want to exercise, as opposed to just teaching them how to exercise.
In this session, we are going to talk about careers in imaging services. My name is Maribel Tharp. I am the Assistant Director of Radiology here at DHR Health. So my path to becoming a radiologic technologist started many, many years ago. I did go to South Texas College, and it is a 2-year program. There are several prerequisites and co-requisites that come with the program. So those prerequisites you need to take beforehand in order for you to apply into the program. But if you have some extra time before the application deadline, then you can also take some of those co-requisites ahead of time and clear those out before. The program coursework itself is 2 years. So with those two combined, the program and the prerequisites, you're looking at about 3 years overall. With the tuition, as far as the overall amount and the quality, you would have to check with STC to see what the tuition costs are. However, there's so many opportunities to pay for your tuition, including financial aid, scholarships, and workforce solutions. In my experience, I didn't come from a home who was able to pay for tuition, so I came from a low-income family, and I qualified for financial aid. And during that, once I got accepted into the program, I heard about a lot of different programs and I did a lot of homework. I Googled everywhere to be able to find the opportunities that were available to me as a student. And I came across Workforce Solutions. I went over there, I talked to someone, an advisor. They directed me in so many directions to apply for different things, and I qualified and I was able to get that. So through Workforce Solutions, they paid for my tuition, they paid for some of my textbooks, a backpack, and even some school supplies at that time. So, it doesn't hurt to check in there, call Workforce Solutions, see what type of opportunities they have. And then during the program itself, I did get a lot of scholarships. I continued to apply for scholarships just for that extra support to make those ends meet and be able to pay for everything that I needed to. So a day in my shoes. Right now, I am an assistant director of radiology, but when I first graduated, that wasn't the case. I came on board as a radiologic technologist. I started working at a local hospital before coming into DHR Health as a surgery tech. I learned how to run the C-arm in surgery, helping surgeons locate areas so that they can conduct their surgical procedure. As a rad tech, you come in, you assess and verify the physician's orders for the exams, make sure the diagnosis correlates to the exam. For females of childbearing age, you want to make sure that there's no possibility of pregnancy. And if there's a contrast medium like iodine that they inject into the bloodstream, you want to make sure that the kidney functions safe. So there's a lot of things that you need to assess and consents that need to be filled out in order to make sure that the right procedure is being done for the patient. As a rad tech, you interact with multiple roles and departments, including physicians, the radiologists plus ordering physicians, the nurses from the nursing floor, from the emergency room, phlebotomists, respiratory techs, directors and administrators. They come around, checking for compliance, with the type of procedures, the cleanliness of the rooms, and some safety team members to make sure everything's working right with the fire safety, the fire extinguishers, and EVS personnel as well that come in between. Rad techs respond to code blues for X-ray, trauma codes for X-rays and CTs, and code strokes for CT. They also assist with CPR when it's needed, especially when it happens in your own department in radiology. As an assistant director of radiology now, I oversee staffing, productivity, employee development, handle a lot of employee compliance issues, make sure that they have their credentials up to date, interviewing and onboarding of new staff, take care of a lot of payroll, time cards and time off requests, approving for vacation time and holidays. I also handle development of presentations such as this and forms, policy forms or assessment forms for our patients. I handle employee issues and some disciplinary actions, and also take in and handle any physician or patient concerns that they have, good and bad. Some fun facts. So some fun facts for radiology. X-ray was actually developed by accident. William Conrad Röntgen discovered X-ray in November of 1895 when he accidentally X-rayed his wife's hand. So you'll see a lot of X-ray images if you Google it of a hand with a wedding ring or an engagement ring. And that was his wife's hand that he accidentally X-rayed. So from there, a lot of development has occurred. And now we have so many service lines in radiology. In 1927, 37% of radiologic technologists were nuns. Today, there are over 330,000 registered radiologic technologists. And one last fun fact, in observance of Breast Cancer Awareness Month, the first ever 3D mammography exam was performed in the US in 2011. And here you'll see some images of some of our imaging specialties. So on the left side, you see a regular, normal chest X-ray. And on the right side, you see an upper GI exam being performed under fluoroscopy. So you see the white part is the contrast that's going through the stomach, and the black that you see inside the stomach is the air in there. So you see how it's starting to go into the small bowel system. And here on this next slide, on the left side, you have a CT of the brain. So you are able to see that. What CT stands for is computed tomography. So it takes like slices, almost like a bread loaf, where it's cut into slices. So when it's scanning thousands of images into little slices like that. So there's a couple of slices that you can see there. So it helps the radiologist to visualize any hematomas, any blood in the brain, like for stroke patients. And on the right side, you see an example of an MRI of the lumbar spine. Down there towards the bottom, you see a black circle through the spinal cord, and that's a herniated disc that's bulging out there. You see some little, almost like fibers sticking down. Those are some of the nerves that are just being pinched there and are trying to get past the herniated disc. And just some helpful tips. If you are interested in radiology, there's just a few things that any medical professional needs. You have to have a huge interest in the medical field. And sometimes radiology is not a field that you think about when you think about the medical field. You think about nursing, you think about being a doctor. Those are two of the major things, but there's so many careers in the medical field. So do your research on that and look at different opportunities. In radiology, it's good to love to understand how things work because there's a lot of physics, and don't get scared by physics, trust me. I know I was, but you'll learn how to understand how X-ray is created and why the images come out the way they do and what you can do to make it better and fix the images. And passion. You have to have a strong passion to help care for people. You know, they don't want to be in the hospital. They don't want to go to the doctor's offices. I know I don't when I do. I don't want to be here. So you need to have that extra compassion and love for people in order to be able to do what you do here as a medical professional. So that is some of my tidbits and information, my pathway to becoming a radiologic technologist. I hope that it inspired some of you to look into this field a little bit further. And if you feel that this might be a career for you, feel free to contact me. If you want more information, get more details. I know this is a short presentation, and I have 17 years, in radiology. So feel free to send me an email. There, my contact information is on the slide. m.tharp@dhr-rgv.com. Thank you all for your time, and I wish you the best in your future. Just remember that every choice you make now at this moment directs your path to where you go. So choose them wisely and take care. Best of luck.
Hello students, my name is Frances Kirkconnell, and I'm the ultrasound faculty for the Health Sciences Institute at Renaissance at DHR Health. And today I'm going to talk to you a little bit about a career in sonography. But first I want to tell you a little bit about my road to sonography. So before I became involved in ultrasound, I attended the University of Texas at Brownsville, which some of you now know as UTRGV. There I was awarded a Bachelor of Arts in Government, and then I became a social studies teacher at Lopez High School in Brownsville. Go Lobos! About 3 or 4 years in, I started thinking about a career change. And so I went back to the University of Texas at Brownsville, Texas Southmost College, which back in the 90s, they were in a partnership. But now they are separate entities. There's UTRGV and Texas Southmost College. At UTB, I applied for the program in radiologic technology, which you may know as X-ray. I received an associate's degree in applied sciences. But during that program, I was introduced to sonography as part of my X-ray clinical rotations at the very end of my program. And well, it was love at first sight. I continued my education at UT Brownsville. I received an associate degree in diagnostic medical sonography. I now have 2 associate's degrees. Now that program was an 18-month program, and I paid for it by working 16-hour shifts on the weekends as an X-ray tech at Valley Regional Medical Center in Brownsville while attending classes, labs, and clinical rotations Monday through Friday. So, as you can guess, I was really tired. Now, after completing my education, I became an ARDMS registered sonographer, and I have been one since 2003. And ARDMS is the registry organization that grants accreditation to sonographers. Think of it as how doctors have to take board exams. Well, sonographers have to take board exams too, and they come from the ARDMS. I worked over 10 years as a sonographer for DHR Health. And in 2019, the Health Sciences Institute at Renaissance created a diagnostic medical sonography program. And I was lucky enough to be chosen to be the ultrasound instructor for the first cohort of the program. Now, I'd like to tell you a little bit about ultrasound basics. Now, as you hear the sound of my voice or you hear each other, you're listening to auditory sound, which is between 20 and 20,000 hertz. But ultrasound is sound above 20,000 hertz, or out of range of human hearing. Just to give you an example, an animal that can hear above 20,000 hertz is a bat. Now, the sound waves, or ultrasound waves, those are used to create images with something we call the pulse echo effect. As you can see in the top image, there is a transducer, and that transducer is emitting sound waves or pulses into the body, and then those sound waves return back to the transducer as an echo. The transducer then transmits those echoes to the ultrasound machine, which creates the image that you see in the middle of the screen, the grayscale image of the profile of the baby in utero. Now, ultrasound has no ionizing radiation, which means it's very safe for patients. And it is also non-invasive, which means there is no needles being used. You will never administer medication or draw blood or start an IV. So if those of you who are grossed out by blood, well, ultrasound may be for you. Now, an average day in sonography, the sonographer is responsible for performing the correct exam ordered by a doctor. The sonographer is also responsible to record diagnostic images for interpretation by the radiologist. A radiologist is a doctor who specializes in interpreting diagnostic images, not just in sonography, but in other modalities like X-ray and CAT scan and MRI. In addition to those duties, a sonographer has to provide a written summary of the exam. Basically, as we measure parts of the body, we have to document those measurements and any abnormal pathology we see in a written summary for the radiologist. So then the radiologist will go directly to those images to confirm our findings. If you look at the top image, that is an image of a liver next to a kidney. We use that image to help the radiologist determine if the liver is normal by comparing it to the kidney. The bottom image is a fetal kidney, which if you look at the yellow dots and lines, those are calipers. And those are calipers that we use to measure the kidney in this case to make sure that the size is normal according to the patient's age. Now at DHR Health, we have over 20 sonographers assigned to 2 hospitals and 6 outpatient facilities. Depending on their assigned location, these sonographers can scan up to 20 patients per day. And during their day, they interact with the radiologists, nurses, technologists from other modalities. They also interact with lab techs, phlebotomists, physical therapy techs, occupational therapy techs, all kinds of people who work in the hospital or in the outpatient clinics. But the most important interaction is with the patient. DHR has very high patient care standards. Here we treat all our patients with respect, courtesy, and compassion. Now, do you have what it takes to become a sonographer? If you have a strong background in anatomy and physiology, pathophysiology, medical terminology, if you have good critical thinking skills, if you have the ability to multitask, and if you have excellent patient care skills, all of these things, all of these qualities combine to make a successful sonographer. Now, how do you enter our program? Our program requirements include a 2-year allied health degree, which is an associate's degree that is patient care related. It can be in any of the fields listed, radiologic technology, respiratory therapy, occupational therapy, physical therapy, registered nurse. And within these degrees, you will probably have to complete college hours in the following: college algebra, statistics, or higher mathematics like calculus. Also general physics or radiographic physics, depending if you have an X-ray degree. communication classes like interpersonal communication, human anatomy and physiology, and medical terminology. And here's a picture of our first cohort in the Diagnostic Medical Sonography program. They will graduate in December of 2020, and we will be accepting a new cohort this summer to begin in September of 2020. Once again, I'm Frances Kirkconnell, the faculty ultrasound member for the Diagnostic Medical Sonography program here at Health Sciences Institute at Renaissance at DHR Health. Thank you for your attention.
Welcome, PATH students. My name is Dr. Jorge Montes, coming to you from the DHR Health Eye Institute. I would like to share a little bit about how I got here and how my career kind of came to be. So first, most doctors actually have a very similar foundation, all of us. And then we deviate based on what we want to do. So I'd like to share with you how I actually came to my clinical pathway, but just keep in mind that the first portion of what we do is very similar in any specialty that medicine has to offer. So first, the good foundation to anything is going to college. So obviously before that, you have to finish high school, get your diploma. The big next step is college. Even recently, college has been one of those things that has come to question as to whether you need to do 3 years or 4 years. Many people do end up finishing just 3 years as long as you have enough credit hours to proceed into applying to medical school. But for the most part, most people will decide, since you've put that time and that energy into actually finishing the 3 years, you don't want to finish and not have a degree. So most people will take those 3 years and actually finish off the next year so that they can not only have their medical degree, but also a bachelor's degree. And it does not matter whether you get Bachelor's of Science or Bachelor's of Arts, or just a bachelor's degree would be sufficient. A lot of questions come from whether you need to get a science-related degree, or can you do a liberal arts degree, a political science degree, or any of those degrees. And honestly, I did get a science-related degree, but standing here now and looking back, really any bachelor degree should be sufficient as long as you have a core requisite, which is a standard that everybody should look into. A couple chemistry classes, some organic chemistries, but if you can do that along with any other interest you may have, it would be nice. Thinking back, I probably should have done things that interest me more than this science, but at that time I was focused on the goal at hand, which was to become the best science student that you could be, but that doesn't have to be the case. If you have a passion in arts or anything else, you can get your degree in what you're interested in. Medical school, even more so nowadays, starting to look at very well diverse applicants. So the applicant pool, making yourself diverse. So having that unique separation between you and the next person. So maybe having an interesting background in economics, or which is also really important in the field of medicine. But after you get your bachelor degree, the next step is medical school. And this can seem daunting. This chart here can seem very daunting, but then the very next step is another 4 years of medical school. And this would be the last 4 years that you're going to pay to be getting trained. College, you have to pay to go to school. Medical school, you have to pay tuition. But after these 4 years, thereafter, although there's still more training to do, you'll be paid something. At least you're not having to borrow more. And so I think that even if we just take a moment to stop here, this at the end of this career is what's daunting, because you have the 4 years of college, 4 years of med school, and some people think that 8 years is too long. But through my own personal experience and through having seen my own friends go through similar different career changes, I've realized that even at the end of those 4 years, when I was finished with med school, after 4 years of college, there were still a lot of my friends that were still kind of bouncing around their first couple jobs. And by the time that they're done with their second job, maybe 2 years at one site, 2 years at another site, you'll be done with your medical degree. And that would be very, very the MD degree was something that I think by that point in time was very stable. So at that point, I had a lot of friends that were already stable into some careers, but some were still jumping around. So I don't see it as a negative, other than that I had to pay for, I didn't earn income during those 4 years. But don't let the 4 years of college, 4 years of med school be something that prevents you from doing it. As long as you don't stop halfway and decide to change at that point, because you'll have a lot of debt and student loans. But thereafter, after med school, you have to do an internship. At least to, now speaking more specifically, this is where we draw a line between all doctors. All doctors have to get a college degree, and all doctors have to get a degree from a medical school. There are two big types of medical degrees that physicians use, and that's Doctor of Osteopathic Medicine, and then that's a DO, and then you have Doctor of Medicine, which is the one that most people know about as an MD. And then here in the United States, they're equivalent. The testing's the same, it's just a different approach to how you're going to treat your patients. Here's where I decided to move on and do more specific training towards what I'm doing now, mainly eyes and eye surgery. And so I started off with an internship, which was 1 year in internal medicine, which was a paid internship. And then I did thereafter 3 years in ophthalmology residency. So that's already putting you at about 12 years after high school, which again seems daunting, but really once you start your internship, it's like your career now. You're practicing medicine. This is what you're going to be doing the rest of your life. So don't look at it as further schooling. It's just more training. It's already start of your career. But things that have to be done in order to actually start practicing in your subspecialty. So since then, at least personally for me, I've been in practice almost the full 7, going on my 8th year now. So that's about where I'm at in my career path. So practicing for 7 years. And let me tell you, it goes by way too fast. Looking at this personally, I did go to Texas A&M for my undergraduate. I got a bachelor's in biomedical science, which again, going back to the beginning, does not have to be in science. But, I wish I would have learned a little bit more about political science, more about finance, because those things help you in life too. But I skipped all of that because I was so focused on science. So I think going back, thinking about personal growth, probably making myself a better person. I don't think I needed all of that science as an undergraduate degree. I could have just learned things that I would never had the opportunity to learn again. I just didn't take advantage of that. So that would be something that I would recommend if you have that. That's the time to do it, is learn what you want to learn, what you're interested in, but use that for personal growth in the future. Med school, I went to the Health Science Center in San Antonio. I really enjoyed San Antonio, but obviously there's many medical schools. Being here in Texas is very unique because Texas has the most medical schools in the entire state than any other state. So I think now they have over 8, but some states don't have any. And in other states, they just have 1 for the whole state. So we have over 8, I think now. I stopped counting, but we have many medical schools in the state of Texas. So it's nice because medical schools do prefer taking in-state students versus out-of-state students. And although Texas is big, it's still per capita, or for the amount of applicants we're getting, still kind of gives an advantage to people who are from their own state, as long as you're open-minded as to where you want to go. So that's the college and medical school. From there, I actually did my residency in San Antonio as well. And so I pretty much, after college, I pretty much stayed in San Antonio. And so I started practicing. So a big question is, how do we pay for this? So there's college, and that's 8 years where you're not making money, and 8 years where bills are due, 8 years where tuition is due. And personally, for me, I just lived off of student loans. And it does get scary because halfway through there, maybe even once you start signing the medical school loans, it gets scary seeing just these loans pile up and you don't see an end to it. I would say that I had some scholarships and grants, but for the most part, it was student loans. And I think this is one obstacle that every medical student is going to face, because most people pay for undergrad school and medical school with student loans, and if everybody feels the same. So kind of keep yourself in an environment where you're around people, how they're managing things. You really have to make the best use of every dollar you're borrowing, so that it's not you're not wasting it, and then you don't have an enormous amount of debt when you get out. But it is really reasonable to get onto a plan that will allow you to pay them off if you actually finish. So the goal is never to do halfway. The goal is to finish. So if that's your goal, then the student loans should not be a problem. I know a lot of other people have decided to work through college, some through med school, but I can tell you that it may work through college. Working through med school is not going to be a great idea. You really need to focus on what you're there to do, and so loans will be a part of the process of getting to this point in time, at least through med school. Undergraduate, if you can manage it and work through it, that's completely acceptable. So personally, talking about my experience, I didn't leave home thinking I was going to do medicine. I left home. I went to A&M actually for their engineering program. I finished my first year there. It was a really difficult program, but at the end of the year, I couldn't say I was the most interested in engineering. But more than that, what scared me was that we went to a conference of engineering companies that were doing hiring and to do internships at their sites, and very few companies attended the year that it was my turn to intern. And that really scared me even at the student level, because I figured if it was this competitive as a student, then I was going to be having to compete at that level in my career. So I really had to sit down a heart-to-heart with myself, what I wanted to do, and I felt that medicine was a safer career path, although I couldn't tell you at that point in time what I wanted to do. So I ultimately did change out of engineering. I went into medicine route, the pre-med route, and I got in. But even when I went to med school, I knew medicine was for me. I just didn't know what specialty. So I started off with ER, and then I went into ENT subspecialties, so the emergency room medicine and ear, nose, and throat specialties. And I wanted to learn a little bit more about the ear, nose, and throat. So I went on a mission trip to Mexico, and they were supposed to have a more in-depth exposure with U.S. doctors that were helping out several communities there. They really needed help with the eyes, and not as much help. There was so much help on the ear, nose, and throat section that we spared a little bit of that help onto the eye section, which is where I came in. And unfortunately for me, at the time, I didn't realize that this was going to be a great thing for me, but they did shunt me over to the eye section, and what they were doing there was getting together some of the blindest patients in that community and operating on them. And the first day that I saw the surgeries was really boring because all I was doing was seeing people operate. But it was the next day when it was time to remove the patch, that some patients that were there being operated on that had not seen their family for 20, 30 years, and have never had met some of their family members visually. Having removed that patch and being there in that room and having people see themselves jump for joy and meet each other for the first time visually, I thought that was just a very incredible experience to be a part of. And we did that several times. I think that week we operated on 200 people. So it was a very emotional week for me and a very eye-opening week for me in the sense that I came back knowing what I wanted to do. Not only at that moment, but for the rest of my life. And I'm still doing that now to this day. So that's how I got into the eye world, and I haven't looked back, and it's still every week that I operate, it's still a very good experience. And so this has led to my current passion, which is cataract surgery. It's what I do for a living. But if you talk to every doctor, there will be a story just like that moves you to do what you want to do. And I think you have to find that in medicine. And you may not always find it when you apply, but you will find it once you get there. But I can tell you that every physician shares the same stories, that they all want to help a group of people in a certain way. And they have a reason, whether it be their family members have gone through the same problems, or they have gone through those problems, or they had an experience like this trying to help someone else, and it was just overwhelming. Nonetheless, if you haven't had that moment now, it doesn't mean medicine's not for you. It just means you haven't been exposed to that type. And I wasn't exposed to it while I was in medical school. So I think it's made me a better person. So outside of the surgeries weekly, on a weekly basis, what does my day look like? Personally speaking, I have a clinic that's 8 to 5. I guess other good things about ophthalmology that it's. I'm not going to say we don't have emergencies, but they're not as common emergencies. So we do have very regular hours, 8 to 5. I do have to take call in the hospital about once every 2 or 3 months, and we interact with pretty much every specialty because the eye affects. Any part of the body, from the kidney disease to liver disease to heart disease and diabetes, everything affects the eye. So we do have to work with every specialty that there is. So I like that communication. We work with other surgeons. We work with other medicine doctors to keep the patient's eyes the healthiest possible. So what skills are necessary to kind of excel in my profession? And I think, honestly speaking, that if you take a person that has the determination and the will to do good, then you're going to do well in medicine. And it really, what it comes down to is grit. Grit meaning no matter what obstacles in front of you, you're going to get up. And if you've been through a hard time, been through financially, emotionally, that's life. Everybody's going to go through that. And you'll hear in the 4 years you're in med school, 4 years you're in training, you're going to hear many stories. I had funerals to attend to. I missed birthday parties. Many things happened during those 8 years, but you just have to get back on and focus on your goal. And if you do that, if you have grit, you can overcome not only this obstacle, but pretty much anything that life may throw your way. So I do want to share, it's one thing to say what we experience, but another thing to show what we experience. So I want to share a little bit about what the experience is usually like during patch removal day. That's really my favorite day of the week, is the next day after surgery. And this is an example of that. So before I start the video, I just want to read the line. So this is a patient that has not seen their family in several years, and he had cataract surgery, is now about to be shown what life is like now that he can see.
Okay, Daniel, now I'm almost ready to bring your hand down from your eyes and you'll be able to see.
Ready as I'll ever be.
It's okay, honey. Everything's gonna be okay.
You're doing great, Dad.
Here we go. Oh my God.
I might finally be able to see. I might finally be able to see my wife and daughter.
Here we go. Now you want to be very careful because your eyes will be sensitive to the light. Good. Now you
Wow!
Can you see?
Yes!
Yeah!
Come here, Alec! I want to see you close.
Say hi.
Hi, sweetie. You are more beautiful than I ever could have imagined.
Congratulations.
Thank you.
Thank you.
Thank you.
So that's just a reflection of some of the emotions that are going through, for the most part, in patch removal day for us. And so it's very, very addicting to be able to do that on a weekly basis and to have that very personal touch with these patients. And it's just something that you cannot pay for. It's a very addicting feeling to be part of, and so that's why we do it. But how do we get there? So this next video shows you very quick, maybe 2 minutes, regarding an actual procedure of cataract surgery. So how we actually get the patients to that point.
DHR Health Eye Institute.
Hello. I will briefly take you through one of my cataract surgeries. I hope you enjoy it. At this time, the eye has already been numbed, and the patient is comfortable. We enter the eye and start opening the capsule of the cataract. It's a very fine technique. The capsule is what supports the lens of the eye. The capsule will be used to support the artificial lens. The lens is separated from the capsular bag through the injection of fluid. The lens can now spin freely. I start breaking the cataract into smaller parts to allow for removal. Careful removal of all pieces begins. Breakup of the cataract is done using ultrasound energy. Fine fibers can remain after the cataract is removed. These are gently removed as well, in a process called cortical cleanup. It's clean and clear now. And we're ready for the lens. Small manipulation is needed to center the lens and ensure appropriate positioning. That's it. We're done. Thank you for watching.
But a couple helpful tips from the beginning, especially for those of us going into or wanting to be pre-med. I think starting from the beginning, what you can do is being active in your community. So there's a difference between, shadowing, which is essential, I think, to know that you really want to know to do this. But having 500 hours of shadowing does not make you a better student, because you're not really helping anybody. You're helping maybe your interest, but you don't need 500 hours of shadowing to make sure that you want to do pre-med. I think those hours would probably be better used in helping other people, like visiting elderly homes or doing Habitat for Humanity, something that'll help somebody else, not just looking inside. And then that'll also look better on any application that you do to medical school. Just remember, study hard. It does take grit. It does take determination. And as long as you have that, you can overcome any smarts deficits. It's really how can you dedicate yourself to this? Because any one topic in medicine is easy to understand. You just have to be determined and take the time to understand it. Set your long-term goals. Stick to the plan. Every long-term goal is going to have bumps in it, but you have to veer yourself back onto course. And as long as you're dedicated to the plan, you should be able to succeed. And something that was very helpful for me is finding role models. So people that are just ahead of you in the same process, and people that are way ahead of you in that same process. And seek to them for guidance as to what you need to do, what you can look forward to doing, and help those people, use those people to help you attain your goals. And thank you for listening.
Thank you so much for joining us. We hope you enjoyed every minute of today's information-packed conference, specifically created for you guys. Thank you, DHR. Our partnership is incredible. Always there, always providing the very best for our students of the region. Please don't forget to share, like, and subscribe to our PATHS YouTube channel. It's on the screen so that you can just click on it, click that code. Also follow us on Facebook and send